monitor, whatever they're calling it. I mean, generally we call it, in the here we call it procedural sedation, so you change the name depending on where you're working.
Mac.
Well, yeah, Max what they call it in the OR, yeah. We don't see, that's what I mean, we don't call it that. So, arose by any other name. Other questions though from that? I'm gonna ask you a question then. Who can I ask? What can I ask? Who can I ask? Marissa asked me, so I can't ask Marissa. Nikisha, because she already was in the OR.
Oh, no.
How about besides airway, of course, because that's an easy one. What are 3 things to check? What are 3 top things to check post-operatively? Airway, of course, airway's taken.
Just trying to make them oriented, consciousness, able to arouse.
Okay, I'll take that one.
Vital signs,
Especially what?
blood pressure.
Beautiful, yeah, so yeah, just think how ahead of time. So blood pressure, heart rate, what are we gonna be doing about the heart rate? Besides counting the number, what are they on in a post-anesthesia care unit? They're on a
Monitor.
Monitor.
cardiac monitor. There's only one Nikisha. Yeah.
Sorry.
So, right, so their neurostatus, their vital signs, especially, cardiac rate, because why could they be having dysrhythmias? Because anesthesia, why else? Chelsea?
Blood clot.
Well, yeah, they could be having some clotting issues, but because of, the whole electrolyte shifts would get so much fluid. So, what, one more thing to monitor. You said vital signs with the one, with the telemetry monitor, and you said neurostatus, something else. I'm sure you did it. You did it. Just don't realize it.
I'm not sure.
Related to their airway, this whole status. So think airway we got, breathing, check with the vital signs, circulation with the blood pressure, you said neuro. What would be the next system? Did you give them a cheesesteak in the post-anesthesia care unit? No. What are we gonna make sure, what are we gonna give them initially, right when somebody's, comes out of the post-anesthesia care unit? What kind of diet would we have initially?
Liquid.
Yeah, well, sips, probably just sips of something clear, liquid, and then advanced is tolerant. Why do we just want sips of clear stuff?
Because everything's still slow.
Yeah, everything's still slow, right, and if they do aspirate it, we want something clear. We don't want them to aspirate the old Starbucks here, that's gonna have particulate in it. So if you're gonna aspirate something, better be clear. We don't want you to aspirate it all. Come on, you're already clicking. True, but even even just somebody comes right at post-surgery, nice little wet the whistle, we're giving them ice chips,
No.
just start with sips, ice chips.
No.
You're not gonna, even though they might want something that's great, they're not gonna glug it down, what's gonna happen? Right. And I have to clean up.
Is that one of the big monitor though, because you want to hear about them?
Yeah, we do, but even just to rinse out their mouth, whatever, All right, so care for person with tuberculosis. Special thanks to Ms. Pickton Walker from our daytime faculty. But now it has Ms. Wright written all over it. So all of them, I'm not gonna read the objectives to you because I'm just trying to save time here. Every lecture really is gonna go the same. Every adult health lecture is gonna go the same. It'll say, high-risk people, the background, how we test for the disorder, the diagnostic test related to the disorder. Then the medications, adverse effects of the medications, care of the patient and their family. That's really objectives for every lecture. When those people, when the Asian woman comes, I have to pretend like I'm really reading them, but I still won't be reading them, it's just gonna be names.
Did you put it
So populations at risk are gonna be people in substandard housing. So who's also gonna have substandard housing?
Poor.
Well, poor people and homeless people. Like if you don't have a home, it's really substandard. So you think homeless individuals, and unfortunately, not always people living in their cars, things like that. Overcrowded situations. So immunocompromised, so somebody who has HIV, who else could be immunocompromised? Brittany Robb. Compromised immune status. Oh, yeah, definitely. Oh, diabetes is always a good answer to. Always can't go wrong with diabetes. Who else? Yeah, all really beautiful, yeah. Or so, yeah, think cancer, because think I'm gonna get chemotherapy is gonna affect my immune system. As I've had, yeah, you could just have a, genetic immune deficiency, true, or some other acquired thing besides HIV. Who else? If you had a transplant, so if you're on immunosuppressant therapy from having an organ transplant, like Sarah said, cancer is grade 1, 2. So if immigrants from countries where TB is prevalent, so I have to just look this up right now, because we always say that, but there's a lot of countries. So the Philippines, a lot of countries in Africa, Angola, South Africa, Nigeria, Cameroon. But it's worldwide, unfortunately. And healthcare workers delivering care to high-risk populations. So other high-risk people, we didn't have any substandard housing. You think prison nurses, nurses on Indian reservation or Native American reservations, high rate of TB also. So if they have inadequate health resources, again, that's gonna be if you're economically underserved. Pre-existing medical conditions, again, like Lori said, Brittany expertly said, diabetes is always a good one. And this is gonna come up again, so I want you to write it right now. When we talk about reactivation of TB, these populations, it's gonna come up, but I want you to write it down a couple times, because you're gonna see it, wink, wink. So TB gets reactivated, we're worried about people who have diabetes, chronic renal failure, because they're always another good population to be immunocompromised. Long-term steroid use, which again would be people who've had transplants or who have immune deficiency or autoimmune diseases also, and malnutrition. So those 4 common to get reactivated TB. So I'll say them again: diabetes, chronic renal failure, somebody on long-term steroids for long-term, and someone who's malnourished. So people with a history of substance abuse, because just going back to our old mental health, seems so old, wasn't that long ago, but people who have substance abuse, generally they have a lot of comorbid conditions too, so you think it's gonna be more alcoholism, IV drug abuse, and they're not living in the best conditions sometimes. And if you have close contact with somebody who has active TB, so meaning you're living in the same household. So you think grandma or grandpa, whoever relative comes from a different country, and now you're all living here, now you're all exposed and have TB potentially. So this pathophysiology is not all nice, it's not just nice, it's important that the most important part to understand is, so mycobacterium, gram-positive, acid-fast, it's just, that comes in when you're sending a sputum assessment, you have to send it for acid-fast bacteria. but that it's really a slow growing bacteria. And because it's so slow growing, it has a waxy coating, that's more nice to know, but that's what makes the drug treatment so difficult, because the bacteria, the mycobacterium itself is so tenacious, it's very difficult to treat just by nature of it. And there's other organisms that are mycobacterium that aren't tuberculosis, and that's how you get false positives on the TB testing. So gets transmitted aerosolized droplets, so what's that mean? Cough, sneeze. So close, frequent, or prolonged exposure. So unfortunately, so that's us healthcare workers. Somebody has active or reactivated TB, that's why, if there's any question, our priority is to put them in isolation. So, and what type of isolation gonna be in?
Negative pressure.
Well, airborne precautions, so
Oh.
negative pressure room, N95 mask. So bacilli to get by our natural defense mechanisms, and so what are our natural defense mechanisms? Yeah, what's natural defense mechanism we have?
Cough,
Yeah,
your,
we just,
your nose, your membrane.
exactly, like, so cough and sneezing, those are our natural defense mechanisms. The little hairs in our nose, the cilia that cough things out, all those, but those tricky bacilli can get through all those, lodge in our alveoli, and then have the snow growth. And so, get a nice feel good slide. What are we all gonna be doing? Because who's involved in this? It's gonna be obviously nursing, but general medicine and infectious disease. So we need an infectious disease practitioner. Because as we're gonna talk about, there's a lot of, we can have drug resistant strains of TB, so need infectious disease. Need respiratory therapy, because it's not all about nursing. Community health, big team. But so early detection, accurate diagnosis, effective treatment, and obviously preventing spread of disease to others. So your book is a little tricky here. I reordered it from your book just for ease of understanding, I hope. Because when you see test questions about tuberculosis, these are the classic symptoms. Fatigue, weight loss, night sweats. So that's important question as initial things. But unfortunately, that could be a lot of disorders. But we couple that with things we already said. Say you've come from a country where TB is really prevalent, or you're homeless, or you're in prison. So put that together with these initial symptoms. So that's somebody I'm thinking, okay, I'm gonna put this person in isolation. So later on the disease, rust color or blood streak sputum. And that's just because of the irritation to the alveoli where the bacteria are lodged. So it's blood streaked, rust because the blood can, be a little bit older. Dyspnea is, remember that one, just difficulty breathing. Orthopnea is Brittany Rich.
When you need to sit up a certain way to breathe.
Exactly, you need to sit up to breathe. And crackles or rails, same thing. That is Sarah. What causes crackles or rails?
Oh, do you have, like, mucus in your airway?
Yeah, well, more so it's like the alveoli are compressed because they have a little bit of fluid there. So when you hear them open up, that's a little finer sounding sound. Not as coarse as rhonchi. It's going to be more in the distal portions of the lung. They can clear with coughing. And then pleuritic chest pain. So pleuritic chest pain is sharp in nature. It generally increases when you take a deep breath or when you're coughing. So it's different from, say, cardiac chest pain where it's a dull, aching sensation. Pleuritic is sharp and increases with deep inspiration. So these are classic signs. These are, I hate to say, it, but like test question ones. So real people might not have all these, but just test wise, what you're gonna see. So in symptomatic infection. So then it goes through, then your book goes through primary TB infection. Says somebody with a little bit of weakened immune response that the tuberculosis bacteria itself hasn't made like the characteristic change that you'll see on the chest x-ray. So this person's asymptomatic, non-infectious, but they are gonna have positive sputum and skin test. Won't talk that much about them. This means they have a positive TB test and they might not know they have TB, but they're infected with it. So a latent infection. So this is the case with most people. They have a latent infection, don't know it. The latent infection gets reactivated, and that's when they're gonna look like that symptomatic picture. So they have an intact immune system. You get infected with tuberculosis somehow, and then this granuloma forms inside your lung. So this, little pocket forms inside your lung. The middle of it gets necrotic and kind of dissolves in your lungs. Bad. And then you'll see this granuloma on the chest x-ray with a big punch-out center. So I tried to look for an image, but really you can't, all the images, you still can't see them. If you really are jazzed about it, you can Google it and see it, but it is kind of hard to see. It's just, in real life, it's easier to see. But it has to be somebody with pretty advanced disease to really see it well. So inactive bacilli are dormant. So this person's asymptomatic, non-contagious. So plenty of people walking around with, unfortunately, with latent TB and don't know it. Know it when it gets reactivated. So this person likely would have a positive PPD or quantiferon, which we'll talk about. So the skin test or blood test.
You said you can see this on the X-ray.
Yes, this is when you see on the X-ray, but they're not having the cough, they're not having the night sweats, they're not having any symptoms. Asymptomatic.
Mm.
So here's clinically, this is where we see most people when their immune system somehow becomes compromised. So it could be a big thing, like the ones we just said, HIV, poorly controlled diabetes, chronic renal disease. And so I'm gonna know they have chronic renal disease by what? What's gonna be elevated off the chart? Yeah, BUN and creatinine. And I mean like their BUNs 60 something and creatinine's 40. It's terrible. And of course, this is somebody like could be on dialysis right before they go on dialysis. So long-term steroid use. What's the population going to be on steroids for long-term?
Asthmatics?
Yeah, so you're seeing asthma, or even more so, somebody has emphysema, chronic bronchitis. So those two, emphysema, chronic bronchitis. If I have some autoimmune disorder, not as much, but can be people who've had an organ transplant. So sepsis, thinking back to old N100, Big Tim, what's one criteria for being septic? We're all going through the memory bank. Sepsis meant I'll give you a little clue. It's with bad infection, so what's one thing you can think of? It's all right, no pressure's on. Don't be pressured. If you have bad infection, you're definitely gonna have so could have increased or decreased white blood cells. Well, in fact, you're gonna have fever. Yeah. So though you can be hypothermic with sepsis too. So fever, so hyperthermic or hypothermic. So it can be increase or decrease, severe decrease in white blood cell count. What's the normal range for white blood cell count? Yolanda?
4,000 to 10,000?
That's a good one, yeah. I'd go with 4 to 11, but 4 to 10 is good too. So it was if it was below 4,000 or way above 10, that's definitely the third septic. And, well, increased heart rate, if the heart rate's above 90, these are the latest septic criteria. And the respiratory rate, so if the respiratory rate's greater than 20, or their PCO2 is less than 32. So the latest septic criteria, and it goes on from here, your fever, so above 100.4 or below 96.8 is sepsis really. If their heart rate's above 90, the respiratory rate is greater than 20, or their PCO2 is less than 32, and the white blood count is below 4,000 or above 11,000.
Do you have hypertension patients?
So it depends, these are just from 2019. Hypotension generally, used to be in it, yeah. Definitely go with hypotension, like the systolics below 100. Worry. And what's the other one we talked about? We get on everybody. Another blood test, besides that white count is, well, CBC is gonna be the white count.
Is it metabolic?
What's the other one?
Like the calcium phosphate?
No. Get warmer, get warmer. No, electrics are separate. Good thinking. One more. We're so warm. We're burning up. Burning up with fever. Oh, before we get to the ABG, do lactate. So that's serum lactate. Remember, the lactate's above 2. And then malnutrition. So we're gonna know somebody's malnourished because of what are our criteria for being malnourished? Weight loss, obviously. Don't say that. But our more high-level nursing ones now are gonna be
Nail
they have
beds.
low. Yeah, albumin. Right? Remember our pal albumin? Albumin keeping fluid in the vessels. And the BMI, think of the BMI too. So BMI normally should be
24,
Below 17.
right, yeah, like I just think of if I'm malnourished, like below 18 is really low. That's gonna be really malnourished. Yeah. Normal's 18 or 24. Don't look up here, it's not me. So all these criteria, this is how, so now my immune system gets compromised. I have latent TB, I don't even know it, I'm walking around fine, don't know it, but something happens, and it doesn't have to be, might not even be this big of a thing. Whatever happens to compromise my immune system, then I'm gonna present with this picture, with these symptoms, the symptomatic affected. So when latent TB gets reactivated, I have the symptomatic picture.
Oh, so it's laying dormant right then?
Right.
And then, okay.
Yeah. Then it gets reactivated. So reactivation of latent TB infection is what that symptomatic part is. Because your book kind of says a little weird. Most patients that you take care of is because the latent one has been reactivated. And then this is just, a little comparison right from the CDC, comparing the latent to the active.
Okay, so just so I got it clear, so primary is just the test was positive, and then latent is positive too, but still no symptoms, and then it doesn't show symptoms until it's reactivated.
Beautiful.
Okay.
Exactly.
And also with the PPD, like you can have a positive PPD but a negative chest X-ray.
Correct.
That just means you're exposed, it doesn't have the infection.
Right. I had had more on that.
Oh, sorry.
No, coming up in just, whatever, within 3 minutes, I think. So, here's the big problem. Our first little star, like all that was important, this is really important too. So we have multi-drug resistant TB because just like everything, we have multi-drug resistant mycobacteria like there's regular resistant bacteria. So primary resistance happens person to person of the resistant organism, one way. Secondary resistance, so that develops during treatment, and so either the treatment regimen's ineffective somehow, or that they have an incomplete regimen. And the reason why I started that is because it's very easy to have an incomplete regimen because sometimes people have to be on these drugs for 2 years. Now, who's gonna take medication every day for 2 years? Not many people. And you can't drink. It's another, that second death now, like, very, and remember, I'm just out of jail or I'm homeless, like, come on, like, this is not looking like a good picture. Not that, again, it's always, not that people might not want to, but do they have the resources? If I don't have somewhere to live, I'm not really thinking about my TB medicine. Or if I have substance abuse problems, not gonna be my biggest priority. So that was really important. So diagnosis, so elements for diagnosis are gonna be chest X-ray result. I'm sorry, let me put them this way. So TB can be skin test or blood test, the IGRA there. So TB time test or IGRA. Chest X-ray and positive sputum culture. So those are 3 little blanks. Chest X-ray, PPD or blood test, the IGRA, and positive sputum culture. So chest X-ray, I know it sounds silly, but really for every test, as we go through our whole med-surg world here, swim through that whole med-surg world, this semester and next semester, you have to know the before and after care if somebody's going for a diagnostic procedure. So X-rays are kind of easy, but people don't know, they have misconceptions. Really for an X-ray, it's just that they have to take things off. X-ray people, this is for all my X-ray tech friends, they get crazy, get somebody X-ray, and they have a bra on or whatever, garments. Because it's not just girls anymore, guys have on girdle things too. So make sure people are stripped down before they go for a chest X-ray. And, if it's a female childbearing age, make sure they're not pregnant. That would be our before care. After care is really nothing, like you can go in their garments if they want again, but generally we're in the hospital. It's nude, it's naked time. And then I know people do get, I don't want you to, be misconceived. They do shield people, though they shield your thyroid, they shield reproductive organs, but still they like to check them, I'm sure. It's not pregnant. So then the PPD or Mantoux test is still performed. Always frequently standardized test question about this one. So this can determine, I should have wrote, if you're affected with Mycobacterium tuberculosis. And so you read it after 48 to 72 hours. And we all probably had this one. They put it on the ventral side of your forearm. And they use it with an intradermal technique, so bing, bing, bing. Chelsea, what size for an intradermal needle? What gauge and length?
Like 5 8.
smaller, like 27, 29, like really thin gauge, and what angle we can put this at, like really shallow angle, just making that wheel. And we're checking that area of induration after the 48 to 72 hours. So in your big old book here, that's heavy as crap. On page 452, that talks about the different areas of induration. Test-wise, it's not necessary to know these different measurements. Just know that you don't expect as much induration, you're not looking for as much induration if they have some pre-existing condition. I mean, if I'm immunocompromised, my body can't mount that response to make a big induration. So if I have some pre-existing condition, that's why it has the wheels as different numbers. Like, you know, you can have a very slight induration, but if I'm HIV positive or had a transplant, that's enough to say that I'm positive. So, not gonna ask you about this, it's just knowing that this is why there's different numbers. And it always, I like when I choke people when they, they go, oh, can you read my PPD? Because when you're a healthcare worker, like we all will be, nurses, if it kills me, they, we're not worried about the color, you're worried about that induration. So we have to get them every year, and I swear sometimes in ER they make it every 6 months. Like I feel like I'm getting this stupid thing all the time, but whatever. And people will be like looking like this. I'm like, if I had it, you could just do just look at it, like woman, man, whoever you are. Like, you don't have to do this whole weird thing, like you're looking for I don't know what. Pretty obvious if it's positive. So, but you can have false positive results. So false positive results come if you have another mycobacterium besides Mycobacterium tuberculosis. Oddly, there's other mycobacterium. The weirdest one, not weirdest one, is the one for leprosy. Leprosy is a mycobacterium. So you're like, lady, are you teaching about the Bible now? Why are you talking about leprosy? But people who have transplants commonly get that mycobacterium, so it's not just a weird thing. Another one gives a false positive if they've had BCG vaccine. So Bacillus calmette-guerin vaccine is given for people in countries where TB is really endemic to prevent them from getting it. So if you come from one of those countries where you've gotten BCG vaccine, then you can't get a TB time test because it's always going to come back positive because I've been inoculated with that BCG vaccine. So they don't, and they usually will know, they'll say, oh, I can't get it because I've had BCG vaccine. And I just have it right here. Yeah, just for anybody who's to read later. I don't put it as a link because we don't, who has time for all that? But if you want to read about it, this is about BCG vaccine. So false positive in general, that means what? That means get a positive result, but means I really don't have the disorder. Anytime you see that term. You can also get false negatives, and I just printed that out upstairs, but I left it there. So sometimes they don't react, but they really can have it. So that's another thing. So that's why 2019 we have interferon gamma release assay is a generic name for it, but QuantiFERON or T-Spot are their two brand names for this. So you could get this QuantiFERON instead of having the TB time test, the PPD test. So the advantage is that the person only has to come one time because, as you can imagine, people don't come back to follow up. And here's people with jobs like, if I'm working, you go to occupational health, get the PPD place. Oh, you have to come back in Friday to get it read. No, I'm not. I'm off Friday. Like, or I forgot, or it slipped my mind, or somebody in my family got sick. Whatever the case is, like for QuantiFERON, you just have to do it one time. It's more expensive naturally. But here's some nice QuantiFERON propaganda about that. So, yeah. Eliminates time for re-shows, you don't have to have as many people, and there's not false positives because it can discriminate for BCG and if it's a non-tuberculosis. I mean, if it's non-mycobacterium for tuberculosis. So, I just know Mainline Health does this quantiferon one, instead of PPD. So that was, and so special, but I was weird with it,